Good afternoon, and welcome to Urology Speaks. My name is Mohammed Aloff, and I serve as the Executive Vice Chair of the Department of Urology. Today's interactive lecture, led by urinary stone specialist Dr. Brian Matlaga, will feature important updates on stone disease research and care, and how our knowledge is helping the Brady to develop improved treatment options for our patients. In a few moments, I will formally introduce our speaker for today's webinar, but let me first thank Dr. Brian Matlaga for his willingness to share his expertise on this topic. We are delighted to see that so many of you have tuned in to listen and participate. First, I want to let you know that today's webinar is being recorded and will be made available to pass the recording along to friends and family who might have an interest in the topic. The advances you will hear about today are made possible through the trusting partnerships between physicians, patients, and families who all share a commitment to our mission. Our dedication to patient-centered care inspires us to ask challenging questions and pursue research that will create positive outcomes for this generation and generations to come. In 2018, one very special patient, Mr. Jerry Stevens, and his wife, Helen, enabled the establishment of the Gerald D and Helen M Stevens Stone Center for Stone Disease through a transformative gift made in grateful acknowledgement for the treatment of Mr. Stevens, Mr. Stevens received here at the Brady. The first of its kind in the nation, the Stevens Center researches all elements of stone disease to provide better treatments, prevention, and improved quality of care for patients with this ailment. It is exciting to be able to share with you the incredible discoveries and progress made as a result of the Stevens' investment. And now I proudly introduce to you my partner, Dr. Brian Matlaga, the director of the Stevens Center for Stone Disease. Dr. Matlaga is a professor of urology here at Johns Hopkins University School of Medicine. He received his undergraduate degree from Dartmouth College, medical degree, and a master's of public health from Tulane University. He then completed his internship in surgery and residency in urology at Wake Forest University, followed subsequently by a fellowship at Indiana University that was supported by the American Foundation for Urologic Disease Research Scholarship. Dr. Matlaga is an internationally recognized expert in the medical and surgical treatment of patients with urinary stone disease. This expertise is built on his academic investigations of the pathophysiology and epidemiology of stone formation, as well as his contributions to the advancement of minimally invasive techniques to battle stone disease. A frequent contributor to the medical press, Dr. Matlaga's research has received both national and international awards, and he's held positions in advisory committees for the American Urological Association, the Endourological Society, as well as the National Institute of Health. After Dr. Matlaga's remarks today, we will have time to answer questions. Please use the Q&A button at the bottom of your Zoom screen to submit a question at any time during or after the presentation. We will try our best to answer as many questions as we can. Dr. Matlaga, the screen is all yours.
Thank you, Dr. Aloff, for such a kind introduction. And thank you, Alyssa, and our wonderful development team here at the Brady for organizing this program. It really is a great way, especially in these pandemic times, to be able to connect with our patients and those interested in what we do here at the Brady. What I will talk about for the next probably like 30 minutes or so is an overview of a couple of things. One is of what we do here at the Brady, and then specifically at the Stevens Center. From a clinical standpoint, we'll talk a little bit about some of our research projects and programs and how we're working to improve the care we're delivering to our patients. And then we'll share a little bit about our ability to train the next generation of individuals who will take the mantle from myself, from Dr. Aloff, and be able to care for us and our children and kind of the future. So With that, we'll go ahead and get started, so you don't have to listen to me talk for too long, because I know the question and answer period is going to be of great interest to you also. So I want to take a moment and just really acknowledge the Jerry and Helen Stevens, who had the great vision to support our work here at the Brady with regards to stone disease. Kidney stones are a bit of almost an orphan condition when it comes to funding for research. A large proportion of funded medical research in the United States is targeted towards oncologic conditions, towards cancer, understandably so. But as a result, some other benign urologic diseases, such as kidney stones, tend to be a little bit underfunded relative. And that can limit our ability to do what we do here at the Brady, which is discovery. And so Jerry and Helen both realized that, and they had the great vision of, with their philanthropic support, what could we accomplish here? And I'll share with you one thing that I think is a really great quotation from Jerry. And so Jerry founded a corporation called RLI, which is an insurance corporation, and serving as the CEO of that, he had a message of the week, and he sent out every week in his term a short message of some insight, some words of wisdom to the members of his team out at RLI. And these were bound into a compendium, which is a really wonderful read. And this is a quote that I found in it that I thought really speaks to what we are trying to do, certainly at the Stevens Center, but I think at the Brady and more broadly, even across Johns Hopkins Medicine. And I'll read this. We live only in the present, not the past, not the future. We live only now. Having said that, we need a future. We need goals. We need challenges. We need a reason to study, and we need to take pride in doing our work well. There's great satisfaction and pleasure to be gained from doing our best, but we are at our best and get the most satisfaction when we serve others. The better we serve others, the more success we will achieve. Think about what you can do to improve your service to others, make those about you glad they talk to you, enjoy every step along life's way. And I think, so much of what I know me personally, but I think all of us at the Brady get satisfaction is that service to others, not just in delivering care, but in also trying to identify how we can then improve the care we're delivering and ultimately improve the health and quality of life of our patients. So, as I said, we'll start off talking a little bit about what we do here from a clinical care standpoint. And I'll show a number of medical images, videos from surgery, and I know some of these may be new to some of you. So I'll walk you through a little bit about what we're showing and why we're showing it. This first image is a CT scan, and the patient is essentially facing us. And what you see is the patient's kidney, and then there's a bright white structure on the just on the left side of the screen. And that bright white structure is a white kidney stone that's trapped in the ureter, which is the tube that connects the kidney to the bladder. And you can see this is a situation where it's a single solitary stone. So in terms of complexity, this may be a little bit lower complexity for us from a treatment standpoint, certainly not from the patient who's suffering from this though. But if we compare that to this CT scan, this is a three-dimensional reconstruction. And what you see in this case on the left side is that white structure that's just below the rib cage, just above the pelvis. And that's a large, complex kidney stone. It's what we call a staghorn kidney stone, because you can almost see how it mimics the antlers of a deer or a stag. And so this is obviously going to be a much more complicated situation than the first picture I showed you. And it's going to need a different approach from a treatment standpoint. This here, what you're seeing is a cross-section of a patient's bladder that what look to be little marbles all collected there are actually stones within a bladder. And so you can see this is another clinical problem for the patients that we can fix and improve their life from that. But this is in a different organ. Again, it's a different complexity. It's going to need a different treatment approach. And so although initially you may have the idea that, all stones are treated in the same way and all stones are pretty similar, you can see it is a pretty wide spectrum of complexity that requires treatment. So how do we treat kidney stones? And again, it depends on the complexity of the situation. And the two big things that drive our medical decision making when it comes to complexity are the stone, what we call the stone burden. So this is just the amount of stone in the kidney. Could be one stone, it could be many stones, it could be one big stone, it could be many small stones. And also the renal anatomy. So where is the stone in the body? How accessible is it? And in what way is going to be the best way to access it? Because we do have multiple approaches we can take, and I'll walk you through those different approaches. So you can see the stone on the left of the screen, that single solitary stone that's in the ureter going from kidney to bladder, is going to be treated very differently than the stone on the right of the screen, which is that staghorn type kidney stone. So what do we do for the less complicated stones? So those are generally treated with what we call ureteroscopy. And so ureteroscopy involves the use of a ureteroscope, which is what this is on the left-hand side of the screen. And a ureteroscope is a small camera that is passed under vision. So we essentially watch it go through the urethra, into the bladder, and then up the ureter into the kidney. And what you're seeing on the right-hand side of the screen are some intraoperative X-ray pictures showing that scope driving around to the different parts of the kidney. And what we do is always guided by some form of imaging because we don't want to do blind procedures. So the imaging that we use is either X-ray, which you can see here, or it's also endoscopically guided. And so what you're looking at here is the inside of the kidney. And this is actually a really cool video, I think, as someone who looks in kidneys all the time, because what you're actually seeing, if you can get a sense, there's fluid streaming out from the surface of the kidney. And so what that actually is, that's actually urine that's being filtered and then secreted into the central part of the kidney. And so what we do is, as we drive through the kidney, you can see it there in that video image, that's urine, that's actually, it's blood that's been filtered, that's the waste products, and that's then to be excreted from the body. And this is the part of the kidney where stones can grow and develop. And all of our surgeries are done essentially on a TV screen. So people always have the analogy, it's a little bit like a video game, and it is, and I'll show you some of the video clips from surgery showing how we actually break up the stones. So apologize. So as we break up the stones, there's really two modalities that we use. One is laser lithotripsy. And the great thing about being in a very technology-focused field, such as urology, and then being at an institution where we can really have access to the latest and greatest technology, is that we can see how we're able to treat patients better as the tools we have to treat the patients improve. And so I'll show you two video clips. So this video clip here, what we're looking at is the inside of a kidney again. The golden material is a stone that's being broken up. And on the 9 o'clock position on the screen is a little blue catheter, and that's actually a laser fiber. And so the laser delivers energy to the surface of the stone, which acts almost as like a mini explosion on the surface and then breaks the stone into smaller and smaller pieces. And so what you can see in this video here, this is how probably 10 years ago, 15 years ago, we broke up stones. We had lasers that could only go to what we'd say is a fairly modest frequency. So you're breaking the stones, you can see, into fairly large pieces. And those pieces either have to be retrieved with a small grasping device, or the patient may have to pass those pieces, which you can imagine these look pretty rough, they have sharp edges, they're probably going to be uncomfortable to pass. If we go, I'll pause this video, and if we go now to this next video, this is using essentially more modern laser machines. And what's happened is, as technology has developed, we can treat stones with what we call a higher frequency, meaning our lasers are pulsed, and they provide a burst of energy in kind of a staccato fashion. 10, 15 years ago, we could treat at maybe 30 hertz. So compared to nowadays, we can treat at 100 to 120 hertz. So we can deliver the laser energy up to 3 times faster. And so what that means, I think it's pretty clear as you watch this video, is now instead of breaking stones into large, big pieces that the patients have to pass, it's almost like sandblasting, that we can essentially just ablate the surface of the stone And you can see it's almost like a snow globe or snowstorm effect of all this little, kind of small little debris swirling through the kidney, because we run a little bit of irrigation solution, some salt water through the kidney as we're doing the procedure. And so with using advanced technology, now from a patient standpoint, instead of having to make multiple passes with the scope through the kidney, down the ureter, grabbing all these little pieces, or letting the patient pass all those little pieces, and then the patient's dealing with passing stones for days and weeks after the procedure, now the patient has essentially just this fine sand material which can be washed out of the kidney or even vacuumed out. We're working on a new device that we're leading a multi-center study across the country of a device that can actually then be advanced up following ablation of the stone and vacuum out all this material from the kidney. And so that's a way we can even treat our patients better. And it's really exciting to be in this field because it is such a technology-focused field. And you can see the practical reality of, as you have better and better technology, our patients do better and better. The fundamentals of the procedure stay the same from a surgical skill standpoint, but you're using just tools that work a little bit better. And as our iPhones keep getting better and better, so does surgical technology. This is the future. So this is a device that's not yet available, but it's an even higher powered laser. And you can see what this is doing on the left-hand side is, it's almost hard to see because it's generating so much debris, but I'll show you, this is just a stone inside a test tube. And the laser is ablating the stone. And you'll see, I'll show you this video on the right because it's a little bit more clear there, I think. Get the video to play. But what it's doing is, here we go, is it's essentially vibrating the stone, but the laser is now firing at several hundred hertz. So it's even 3 or 4 times faster than, kind of the modern laser that we're using nowadays. And you can see as this goes on, it really just almost vaporizes the stone into a slurry. And this is in real time. This isn't, in some speeded up compressed video. So you can see we had a stone that was about 1 centimeter, and we're probably like maybe 10 seconds into treatment of it, if that. And you can see how fine that debris is. And as you continue to ablate it, it ablates into just finer and finer debris. And so this is a device, again, as it comes to market, we'll want to have something like this in our surgical practice, because what is this going to let us do? It's going to let us ablate stones even quicker into finer material, which translates into shorter anesthesia times for patients. It translates into quicker recovery because of that less anesthetic. And the patients don't have, again, passage of stone fragments after treatment. So it's really, I think, a very exciting time to be in urology, certainly, but I think in stone management, because we have just a playing field that's changing so quickly. Now, what about for patients with larger or more complicated stones? Because you can imagine that for a modest stone burden, you can go up and treat the stone with a laser, ablate it into that fine debris, and then that fine debris can either be vacuumed out of the kidney, or if it's a small amount, can be spontaneously passed, meaning irrigated clear from the kidney. But if you go and think about that staghorn stone that I showed you at the beginning, that's really occupying almost the entirety of the inside of the kidney, it's really unreasonable to think that you could go up there with a small scope and a laser fiber and ablate several centimeters of stone. You'd end up with so much debris that there's just not a feasible way that can be evacuated from the kidney. It would be almost like pouring a clump of wet sand down a drain. It would just it would form a cast of the ureter, and it just wouldn't ever clear. So for those cases, we rely on a surgery called percutaneous nephrolithotomy, which is a mouthful. And so we, for that reason, call it just a PERC, or a PCNL procedure. And this now, instead of taking what we call a retrograde approach, meaning looking a scope through the urethra into the bladder and then up the ureter into the kidney, we take a more direct approach into the kidney, and that is through the back. So this is now a more invasive operation. It's more invasive because by entering the kidney directly, we have a different armamentarium of instruments that we can use to fragment and evacuate large volume stones in a more efficient manner. And so what I'm going to do here is, this is a video that we were asked to make to show essentially the Brady technique of how we do this operation, because we do things, in a unique fashion here. So the video is, I don't know, probably a good 15 minutes long. I'm not going to make you sit through it. But what I will do is I will speed through to various points in it and show you what we're talking about when we talk about a PCNL procedure. So this is a patient that we took care of here. He showed up to the emergency room with a stone that was obstructing the kidney, and he also had an infection. So this is the CT scan. You can see all this white material in the kidney is a stone. And you see here the kidney, and you see all of that stone within the kidney. And so this is more stone than you could ablate with a laser. So he had what is called a nephrostomy, which is a little drain that's placed into the kidney. It allows the infection that was associated with the stone to drain or to clear, and we can then come back in a non-infected state to treat the stone. And so that's exactly what we did. I'll speed up to show you essentially what we think of. And so what we have to do is we have to identify where in the kidney do we want to access the stone, and then how would we do that. And so in this case, for various anatomic reasons, we thought the lower pole of the kidney would be a good place to access the stone. And so then how do we do that? So it's, again, like everything we do, it's image guided to some extent. And so we use X-ray imaging, and then to access the kidney, and then we use endoscopic or camera imaging to see, visualize, and break up the stone. So this is the beginnings of our access. And so what you can see here, I'll pause the video, is this little tube going into the kidney is that nephrostomy. And then through that, we inject a little bit of X-ray dye. So now you're seeing the X-ray dye give us essentially a silhouette of the kidney and what we call the collecting system, which is the space that urine is secreted into, and that's where stones form. And so what we're seeing here is that there's a large stone in the lower pole, and the kidney itself is fairly dilated or swollen because the stone has been there likely for many, many years, because for a stone to grow to this size, it takes some time for that to happen. But this is what our planning approach is of how we're going to begin to think about a safe way to enter the interior part of the kidney. We always have to remember the kidney gets about 20% of the cardiac output. So 1/5 of the blood that's leaving the heart is going through the kidneys. So it's a very, very vascular organ. So you have to be thoughtful and knowledgeable about where you're going to enter the kidney so you can avoid the blood vessels that are supplying the blood to the kidney, and essentially try to enter the kidney in what we call a bloodless technique. And so for that, what we do is here, this is essentially what we're doing in the operating room. So you can see here, the patient is laid out, so they're laying on their stomach. They're positioned almost kind of like Superman in what we call a prone position. And the surgeon is standing to the left-hand side of the screen. Those are the surgeon's hands. And the cutaway or inset image is a fluoroscopic image. So that's an X-ray image. And what we're doing is we're using X-ray to try to pick a pathway into the kidney. And we take that pathway through something we call triangulation. And all that means is we take two planes, so a horizontal and a vertical plane, and position within those two planes our point where we want to enter the kidney, and then try essentially by freehand to guide our needle directly to that point. So this is where kind of the skill and the art of this procedure comes in, because you want to guide it to that point in a way, like I was saying, that avoids things that you don't want to interact with, like blood vessels, organs around the kidney, like the liver, the spleen, the colon. And so we can guide ourselves with CT imaging, plus with which tells us where things are, plus with X-ray, which takes tells us our path. And so what we're doing now is we are taking that triangulation approach. So you can see we're moving the needle around, we're moving our X-ray around. We're figuring out what is going to be the safe and most expeditious pathway to get ourselves to the stone in a safe fashion. We then, again, we're moving the X-ray. So it's a bit of a process as we do this, but this is, again, really, I think, the most important part of the procedure. And so ultimately what we will do, and I'll fast forward a little bit here, as we pass the needle into the kidney, you can see this is our final sort of push into the kidney. So you have the surgeon's hands. You can see the very, very fine needle. It's the same diameter needle as you would use to start an IV, for example. So it's a very fine needle, but it is a very a little bit longer needle than an IV because it has to go actually through the patient's flank into the central part of the kidney. And so what we're doing here, now you can see the needle has crossed into the kidney. So you have the X-ray dye is filling out the silhouette of the kidney, and the needle is now resting within that silhouette, telling us that we have our access to the kidney. So the next thing we have to do is we have to maintain a pathway from the outside world into the central part of the kidney where the stone is. And so to do that, we use what we call a guide wire. And so what you can see here, these are the surgeon's hands. That very fine black material is only 0.038 of an inch in diameter. It's a small little guide wire that we're advancing into that central part of the kidney. And you can see the guide wire is kind of coiling in the kidney there. And that guide wire now serves as our path from the outside world where the surgeon is to the inside of the kidney, which is where the stone is. And now we have to come up with a way to connect those two worlds so that a camera can be passed into the kidney to get at the stone, break up the stone, and remove the stone. So there's various different catheters. And again, this is where our technologies help us that we can use to kind of guide our guide wires into the kidney where they really need to go in the right place. And so this is a bit of a process. And as we do this, we then need to take that 0.038 of an inch connection and we need to make it a little bit bigger. So the scopes that we use are about little under 1 centimeter in diameter. So small, but still big enough that we have to make a 1 centimeter opening into the kidney. And we do that here. This is we're passing something called a balloon dilator. And so this is a high pressure balloon similar to, in concept, what they use during angioplasty to open up narrowed blood vessels. And so we inflate this balloon up to about 20 atmospheres of pressure. And at that pressure, we dilate a path to the kidney. So the beauty of this operation is the only sharp object that's used is the needle that we pass into the kidney. After that, there's no other sharp objects. We're doing essentially what we call radial dilation, which is a very atraumatic way to create an opening in a very, very vascular organ like the kidney. So as we blow up our balloon, which you can see here, now that little guide wire has become 1 centimeter in diameter as the balloon has dilated, we can then pass something called a sheath into the kidney. And that's what the surgeon is doing here, is they are essentially screwing down the sheath over that little balloon. And then this is now our pathway into the central part of the kidney, because we'll take the balloon out and you have a 1 centimeter opening that is advancing into the kidney. And you can see when we do this here at the Brady, it's really a very bloodless operation. And this comes from the whole team we have working, our X-ray technologists, the nurses, the surgeons. You can see there's a little bit of blood clot in the kidney there. And once that's removed, we'll have access to where the stone is. And we're using a device called an ultrasonic lithotripter. So we remove that little blood clot. We can now look in the kidney, and this device, it's a metal probe that will, if you put it up against your hand, it would kind of tickle. But if you put it up against a brittle structure such as a stone, it will grind the stone down into small fragments. And then it's also hooked up to a vacuum to suction, which it can then suck or vacuum out all of those fragments from the interior part of the kidney. So it's a way that when a patient leaves the operating room, he or she has no stones left in the kidney. All the stones have been removed. And so it's pretty amazing to have a patient with, 4, 5, 6 centimeters worth of stone. And by the end of the operation usually takes 1.5 hours to 2 hours. They are what we call stone free. So that's, kind of as the stone burden gets larger, what we really have to do for those more complex situations. So what I want to now shift a little bit of the focus of our discussion to is from the actual clinical care to the idea of discovery. And discovery is something that really guides us here at the Brady. It's, somewhat of our North Star, if you will. It's a broad-based phenomenon. It's not just benchtop research or data analysis. In the Stevens Center, we want to characterize the field of stone disease from the macro. So that's high level, kind of 30,000 foot overviews, to the micro, to the actual, pathophysiology, or the why do stones form. And we want to develop knowledge that's ultimately going to improve care in a patient-centered approach. So the macro, so this is a research project that we worked on for the National Institutes of Health, and it was something called the Urologic Diseases in America. And it was a project that the NIH asked us to try to help them understand what we call the burden of urologic disease, or how does urologic disease affect the American population. And so it was a really cool study because you can use very, very large data sets to answer these questions. So you can use things like Medicare data, you can use national surveys, something called NHANES, and then you can also purchase from private corporations. So there's a corporation called Optum, which aggregates healthcare data from private insurers. So United Healthcare, for example. And these data are all obviously de-identified, so you don't know, kind of the individuals in the data set, but you can learn about how patients with certain conditions are treated in the healthcare system using essentially what's called insurance claims data. And so this project provided funding from the NIH to do that. And what we're able to do is to, for example, learn about the prevalence of kidney stones. So among Medicare, if you look over a 10-year period, so in this case, the 10-year period was 2004 to 2013, you can see over time, are kidney stones increasing? Are they decreasing? And unfortunately, over this time period, kidney stones, you can see as the curves are going up, kidney stones are increasing at a fairly great rate, almost doubling within a 10-year period. And so this becomes, to some extent, hypothesis generating, meaning the answer to the question of what's going on with kidney stones, are they increasing, decreasing, then prompts a second set of questions. Why are they increasing and decreasing? Is it increasing obesity? Is it increasing diabetes? Are there other comorbid conditions that are driving it? So it helps begin to ask questions that can help us figure out of what are risk factors for kidney stones. We can also look at how kidney stones are treated. Are they treated with some certain surgical procedures more commonly than others? We can look at how they're diagnosed. So this is information as to how kidney stones are diagnosed by what modality. And you can see that most kidney stones are diagnosed with CT imaging, which is great because CT scans are really a gold standard imaging study. But there is a concern that, are we overutilizing CT scans, because CT scans do provide a high dose of radiation to patients. And is there a way to use ultrasound, which you can see here in the yellow line is not widely utilized in the United States to diagnose kidney stones? And is there a way we can work to increase, for example, educational initiatives for physicians to start using ultrasound more so than kidney stones to diagnose, or more so than CT scans to diagnose kidney stones? So it can lead to pathways of the improvement in the quality of care. As I said, we can also look at surgical procedures. So this is showing us how patients with stones, one, that more and more surgeries are being done for patients with kidney stones over time. And that makes logical sense. If more patients are being diagnosed with kidney stones, there's probably going to be more surgeries that go along with those diagnoses to treat the stones. But you can figure out how stones in this country are treated. Most stones are treated with what we call ureteroscopy, which is the images I showed at the beginning, using the laser to ablate the stone. And we can look at pharmaceutical utilization, because all insurance plans, whether it's Medicare, whether it's commercial insurance such as United Healthcare, they all track pharmaceutical data, what prescriptions are filled by what patients. And here you can see that opioid prescriptions are the line in the orange, which is way above all the other prescriptions. A large proportion of patients with kidney stones are prescribed opioids. And to some extent, yes, maybe that does make sense because we know stones are painful, but especially knowing now what we know about opioids and the risks associated with them, it's another way, just as the imaging studies, it's a potential way to improve how we image patients in a way that doesn't expose them to radiation. Now we can identify, okay, perhaps we're overutilizing opioids and we should start look at, one, developing care pathways so that we take some of the variability of some physicians are overprescribing opioids, so we can try to remove some of that variability. And we can also look at physician education programs to help educate physicians on non-opioid alternatives to try to reduce our reliance on opioids in this case. So this, kind of summarizes, I think, from this NIH-funded study that we did, that we really learned that a lot of patients with stones get CT scans. The CT provides great information, and can we take some of that information and take that our knowledge that we're doing a lot of CT scans, and try to pull some information out of those CTs that will help us guide patient treatment better. And so our idea here was to say, well, what else can we do with data from CT scans? And so in this case, again, so much of what we do, certainly at the Stevens Center, but at the Brady and at Johns Hopkins broadly, is collaborative. It's multidisciplinary. And so we can work with, for example, nowadays computer programmers are really being utilized in so many research projects across medicine. And so we can work with computer programmers who have expertise in what we call image processing. And so this is taking a imaging study, such as a CT scan. And although the physician sees just the picture of the CT scan, there's a lot of data within that picture that are embedded in it that we don't see, but the data are there. And if you work with individuals who have a deep understanding of how to access those data and what those data can tell us, we can improve how our CTs are performed and improve our decision-making from those scans. So for example, here we can take the scan and automate its interpretation. And then to reconstruct the stone, so you take a two-dimensional image, we can reconstruct it in a three-dimensional image. And then with that three-dimensional reconstruction, we can get deeper information about how fragile a stone is or how hard a stone is, which can then help us optimize how we're going to treat the stone from a laser standpoint. We can optimize the settings used for laser stone fragmentation. And so with computer programmers, they can write us programs, and that's what they did here in the screen, is wrote us programs that can take CT data from a CT scan, and automate the interpretation, and then essentially provide us a worksheet with, okay, this is how hard the stone is, this is what the three-dimensional view of the stone is. And from that, we can know better what laser settings and what treatment approaches those patients will do best in. We also work with improving our care. So the idea of modeling surgical procedures before we touch the patient. And so I'm sure many of you, if not all of you, have seen 3D printers that you can print things in 3 dimensions. And so this is something we also can do, that we can take CT imaging, we can take the data from that CT scan, we can put it in a program that we then connect to a 3D printer, and then print a 3-dimensional reconstruction of a kidney stone, for example, or a 3-dimensional reconstruction of the collecting system, which is the anatomy of the kidney that the stone resides in. And that does a couple of things. One is, if we want, we can model our surgical procedure before we ever touch the patient. We can essentially have a mimic of the procedure before we do the operation. And then also we can use these from a training standpoint. Obviously, one of the parts of our tripartite mission at Johns Hopkins is education. And so we can create a perfectly modeled 3-dimensional reconstruction of an actual stone in an actual kidney from an actual patient. And then our trainees can work and train on those models. So again, you take them out of that learning curve. And so by the time that they are in the operating room, they are proficient at the procedures because they learned in a laboratory environment. What about from a surgical treatment standpoint? So you can see here, this is another video of us breaking up a stone. And the video on the right-hand side shows what happened is after you break up the stone, we grab the stones with these little devices and remove them from the kidney. Now we're doing a little bit less and less of this now that we have high-frequency lasers, but in some cases, this is still the approach we take to treating the stone. And for that, we really want to have an understanding of how big those stone fragments are. Because if the stone fragment is too big, it won't fit out through the ureter, and it potentially could get stuck in the ureter, which is that tube going from kidney to the bladder, which is a potential problem. And so we wanted to say, is there a way we can make ureteroscopy safer for those settings where you're actually doing what we call basket extraction, meaning grabbing and removing a stone fragment from the kidney? And we partnered again with computer scientists that are way, way smarter than I am about image processing, and they can write code for us. And then with that code, we can actually develop a way in the endoscopic environment to actually measure those stone fragments and know how big they are before we take them out, making this a much safer procedure. And you can see this is just a number of different ways we validated it. We can run a man versus machine study, meaning ask surgeons to measure the stones and then compare that with what the computer measures the stone at. And we see that in this case, the software outperformed trained urologists in its ability to accurately measure kidney stones. This study was a cover article for one of our journals. And if we look at non-surgical care, I mentioned a bit about the opioids. As we all know, the United States is in the midst of an opioid epidemic, and this certainly is an opportunity to improve healthcare. What we did is wanted to develop a set of guidelines for how opioids are prescribed for patients with kidney stones, as well as those undergoing other minimally invasive surgical treatments. And our ultimate goal is to move towards an opioid-free or a minimally use opioid approach. And we developed a consensus statement that we then disseminated to the urologic community as a way that this is essentially the Brady approach of how to optimally manage opioids in the perioperative period after minimally invasive surgery. We can do other studies looking at sampling urine from kidneys to try to understand metabolic defects. We can look at kidney injury markers. So there's a whole host of different ways that we can approach our research. But I want to spend, because we have a few minutes left before we close, I just want to spend a few minutes looking at the next generation. And so these are the individuals we've trained, and we're really very proud that we're populating very prestigious institutions with individuals that have trained here at the Brady. Our present fellow, Dr. Eric Katz, who is actually unfortunately in the operating room right now because stones never really stop coming, is our present fellow. This is something that really gives us great pride. So I'll wrap up here. Our goal at the Stevens Center is to improve the treatment of patients with stone disease through clinical and translational research programs. We want to provide medical and surgical care in a way that minimizes the morbidity and increases quality of life for patients suffering from stone disease. And finally, we want to educate the next generation, the future scientists and clinicians, in the treatment of patients with urinary tract stones. So I'll pause there. Oh, Dr. Katz is on. So Dr. Katz, thank you I'm glad you got out of the operating room. And if you want to say just a few words about the fellowship and what your experience has been and how you see that playing into your career growth.
Yeah, so this has been can you hear me?
Yeah.
Okay. This has been a wonderful experience for me. Training-wise, also mentorship-wise. I currently am under the training of Dr. Matlaga and Dr. Aloff, doing stone procedures with Dr. Matlaga and learning about the medical management and surgical management of kidney stones, as well as robotic surgery with Dr. Aloff and the indications and use of that for various urologic diseases, including prostate cancer and kidney cancer. And it's been a wonderful experience for me. It's given me an opportunity to really hone my focus on kidney stones and minimally invasive surgery, both in learning the techniques of ureteroscopy and percutaneous nephrolithotomy, but also in learning about robotic surgery as well. And then given the opportunity, it's been a wonderful transition year, essentially, where I continue to grow as a practicing urologist, but I have the mentorship and leadership and support from Dr. Matlaga and Dr. Aloff. So that's all been really wonderful. And I completely agree with everything you said about understanding and utilizing the technology and the way that it has advanced our ability to treat patients with kidney stones and our ability to help patients, especially in terms of the lasers we're using, becoming more minimally invasive with every different approach. So overall, it's been a great experience for me. I really appreciate the fact that I've had this opportunity, and I plan to use this as I'm going to be a minimally invasive stone specialist moving up to the Northeast next year. I think this will be a huge benefit to the way that I practice urology, certainly to my patients as well. and I'm just appreciative of the opportunity. So thank you.
No, thanks for joining us.
Well, thank you both so much for this wonderful presentation. We have a lot of interesting questions, and we'll just, without further ado, get going with some of these questions. To both Brian and Eric, there are a lot of questions about prophylaxis or prevention of kidney stones, and I'll read a couple of sort of the questions. Do you recommend prophylactic dose chlorothalidone and potassium to prevent kidney stones? But then others have asked about drinking sufficient fluids, diets that are considered authoritative in this arena. Can you guys speak about prevention and pharmacotherapy, perhaps? Briefly.
Yeah, no, so I think it's incredibly important because kidney stones are a recurrent disease. And meaning if you've had one kidney stone, you have increased risk for having another in your lifetime. And depending on the research study you read, that risk is anywhere from 20% up to 50%, which is high recurrence risks. And so then the question is, what can you do to try to reduce that recurrence risk down to the population risk, which is about 10%. We can never get it to 0%, but our goal is to get the risk down to about 10%. So one thing that we can do, and we really tailor our interventions based on the severity of the patient's stone risk. So one thing for patients at what we'd say are low risk for recurrence would be dietary changes, as you alluded to. And so from a dietary standpoint, what do we recommend for our patients? So a stone is nothing more than a collection of crystals all stuck together. And there's different types of crystals. Most stones in this country are calcium-based stones. They form from calcium crystals. So the best thing you can do to reduce the crystal density in the urine is to increase urine volume, which comes from increasing fluid intake. All liquids count towards that. Water is obviously best, but even Coke, Diet Coke, and coffee count towards that goal. There's no liquid you can drink that is going to increase your stone risk, but there are certain fluids that are better than others from a stone risk reduction. So as I said, water is the best, but following that would be citrus-containing beverages. So this would be lemonade, orange juice. Now, some of the beverages, such as orange juice, can be problematic because they have a high sugar load. But then other things such as artificially sweetened clear sodas, that's like the Sprite, 7-Up, Sierra Mist, those types of sodas are rich in citric acid. Things like Crystal Light is also very rich in citric acid. So from a fluid standpoint, that's what we would recommend. Our goal is about 2 liters per day. And we say that because our goal is a urine volume of about 2 liters. If you're outside in the heat playing golf, yard work, in the summer, you're going to need more than 2 liters to get that 2-liter urine volume because you're going to have what we call insensible losses from breathing, sweating, and the like. From a diet standpoint, a lot of it is what our mothers told us growing up of eat a healthy, balanced diet. But what does that mean? If you're looking for a specific diet, the diet that I would recommend is the DASH diet, which is DASH. And it's a diet that was actually pioneered here at Johns Hopkins with our internal medicine group. That's a very strict low salt diet that's very rich in fruits and vegetables. And that has been shown to reduce stone risk. Even though, as I said, stones are commonly contained calcium, we don't want you to cut calcium out of your diet because that's not healthy for the skeleton. So our goal is an intake of about 1,000 to 1,200 milligrams of calcium per day, which is a recommended daily allowance. Animal protein is okay, just not like a porterhouse steak every night, but about 6 to 8 ounces of animal protein per day, which is about the size of a deck of cards. The other part of the question you asked is, what about medical therapy? And so, as I said, we stratify our recommendations to reduce stone risk really based on what we perceive to be the severity of stone recurrence. So if you were, again, going back to those images I showed at the beginning, the patient that had first-time stone event, small stone in the ureter that just either required ureteroscopy or passed on its own, we're probably going to stick with mostly dietary and lifestyle recommendations. But if you're an individual that had that staghorn stone, or if you've had multiple stones over the course of your lifetime, those are the situations where we're going to be more intensive in our risk reduction, and we'll use medications like, as you said, chlorthalidone, potassium citrate, potassium chloride. The dosage and the agents that we select are based on metabolic evaluations, which really result from a 24-hour urine metabolic study, which gives us an understanding of what someone's stone risk truly is, and then lets us tailor therapy from that.
Brian, a lot of comments in the questions saying that patients of yours are grateful for the care that you provided, and them avoiding emergency procedures and what have you. So just to kind of pass on the good wishes from your patients. Can you comment on, if someone has a stone that's passing down the ureter? Clearly it's painful, and it's perhaps one of the most painful experiences someone can have. Can you talk a little bit about what one can do to help the stone pass? And I'll throw in that I've certainly read in the sort of lay press of some provocative things that one can do to help pass. Can you comment on those? Because I think it'll be of interest, just at least as an interesting aside for the audience.
Yeah. So certainly, if you go on like the internet, I'm sure there's as anything that you search on the internet, there's going to be a lot of stuff that's not really grounded in true like medical reality. Is there anything you can do to promote the passage of a stone? So if we restrict kind of our discussion into like medical, like generally accepted medical therapies, patients will ask, and I think these are always great questions, of if they drink like a bunch of fluid. Like I know one patient said that he was told if he has a stone, drink a 6-pack of beer because it'll take care of the pain and it'll flush the stone out. I don't know that that's true, but kind of in that spirit, there have been studies done where they take someone who's in the ER who's passing a stone, and they give them through an IV a couple liters of saline, of salt water, with the idea that that bolus of fluid will, essentially push the stone out of the ureter. It didn't work. Those patients were no more likely to pass a stone than someone that, just essentially maintained normal oral hydration. For a long time, we were using medications called alpha blockers, which is Flomax is one of them. They're medicines that were originally developed for men with enlarged prostates, but there was a thought that they may also, in addition to relaxing the prostate and making it easier for men to urinate, that it would work for both men and women to relax or dilate the ureter to make it easier for a stone to pass. It became very much a standard practice of ours. In recent years, there were 2 well-done randomized controlled studies, one from the UK, one from the US, that was an NIH-funded study in the US, that found that patients with alpha blockers were no more likely to pass stones than those who received a placebo. So at this point, what we would say for someone passing a stone is there's not, unfortunately, an agent that we can give you that's going to promote the passage of the stone. What our goal is to maintain pain control. Generally, we try to do that with non-opioid medications and maintain just good fluid hydration, good fluid status. And that's the best thing, honestly, that we can do at this point in time for stone passage.
Great. And I had read in the lay press, being on roller coasters can help, inversion therapy and roller coaster riding can help pass stones. Sexual activity, I think there's been a couple of sort of not well done studies looking at that. So very interesting area. Brian, I'll ask a brief question and then I'll make a comment. Are there any medications that are common medications that our patients as they age would be on that would increase the risk of kidney stones?
Yeah, so it's another great question. And there are certain medications that patients can be on that can increase risk. And there are also medications that can decrease risk too. The ones that we see most commonly utilized that can be associated with an increase in stone risk is one, Lasix. So Lasix is a diuretic. It's often prescribed to patients with some component of either heart failure or potentially like high blood pressure, because it's a very, very potent diuretic. That can actually increase the amount of calcium in the urine, which can then promote calcium stone formation. There are other diuretics. You mentioned chlorthalidone, which is a type of a thiazide diuretic. That will actually reduce stone risk, and is actually a medication we use for patients who have too much calcium in the urine, we use that to pull the calcium out of the urine back into the bloodstream. There's another medication that is called topiramate or Topamax that is used for multiple indications. It was originally developed as an anti-epileptic medication or an anti-seizure medication, but it has fairly good effectiveness in the treatment of migraines also. That creates a condition that we call distal renal tubular acidosis, but it's basically a long way of saying that an environment in the urine where calcium phosphate stones like to form. And it's something that is strongly associated with the medication, but if you have bad migraines and it's the only thing that works, we can give you other medications to counteract that effect of it. So to try to bring everything back in balance.
Great. There are a few questions about stone disease. Is it a disease or is it a multitude of diseases? And then there's also a question about bladder stones, which obviously are a little bit different. And I can comment a little bit about this based on my understanding. Clearly, stone disease is not one disease. Some people have stone disease because of a metabolic problem. Basically, they produce urine that's high in a certain, let's say, calcium, as an example. Others will get kidney stones because of an anatomical problem. You know, what part of their kidney doesn't drain very well, so urine sits there and stones crystallize. And that's why they have stones. You know, there's something called medullary sponge kidney, for example. There's cystinuria, which is a metabolic problem that is specific. There's hyperparathyroidism, which was commented on in the Q&A. And as my wife, being a bone metabolism expert, I have to comment on, and that could be virtually cured by parathyroidectomy if that's why one is having, hypercalciuria. Bladder stones are, however, a unique entity, and there's a different pathophysiology that forms those stones. While bladder stones can be kidney stones that simply fallen into the bladder, more likely, though, it is a disease of aging males or a problem with emptying your bladder. So as we age, if we're males, we get enlarged prostates. We don't empty our bladders as well. The urine sits in the bladder, and that increases our risk of forming bladder stones. Women can also have bladder stones if they have a problem emptying, but more commonly, it's the enlarged prostate that gets these stones to form in men who are older. And then the question was, do we solve that problem surgically similar to this? And I would say yes. In the past, we'd make big open incisions to open into the bladder and get the stones out of the bladder. And now, with techniques similar to what Dr. Matlaga described, we can go through the urethra into the bladder, or we could put a needle into the bladder and do a perk, just like that procedure, depending on the size of the stones. And typically, we would want to take care of the obstruction as well, so that we can not form them again, although sometimes taking care of the irritation can help. Let me see here. Somebody was concerned about you, Brian, and said, how does the surgeon avoid X-ray exposure given all of this? And I know that there's studies looking at interventionalists that use X-ray and the increased risk of, say, cancers in the doctors. Can you just briefly comment on that, and then we'll wrap it up?
Yeah, so I very much appreciate the question. And it is something that we have great concern about. We take a number of approaches to mitigate our exposure to that with various lead aproning, shielding from the X-ray source. And then the other thing is that with proficiency comes reduced X-ray utilization, which makes sense. If you are better at the technique, you're going to rely on X-ray much less than someone who is making a lot of passes with the needle or movements with the scope. And that gets in a little bit at what I was saying about our education of that, before the trainee has touched the patient, they've performed this many, many times in an inanimate setting without using X-ray. So it really is, our goal is to make our individuals as proficient as possible, which will result in as little X-ray as possible exposure.
Well, thank you, Brian. There's so many more great comments and questions, and maybe this is our cue to do this again. given the great interest in this topic. Thank you, Dr. Matlaga and Dr. Katz, who had to run back to the operating room, ironically taking care of a stone patient, for laying out this information with such clarity and promise for this disease, and for answering the many excellent questions. Obviously, a big thank you to our audience and guests who joined this webinar, and for the continued support of the Brady and Johns Hopkins Medicine. Without you, our work would not be as impactful or meaningful. Should you have any questions about how to support any of our efforts mentioned today, please reach out to the email address or phone number listed on the screen. There's also a QR code that you can point your phone cameras to. Finally, if you enjoyed today's session, please consider joining us on Thursday, May 19th, for an in-depth discussion on innovations in minimally invasive and robotic surgery with me and my fellow faculty members, Dr. Misab Han, Dr. Amin Harati, and Dr. Charlotte Wu. And thank you again for spending time with us today. Stay safe. I know I always enjoy these sessions, and I thank you again for making time in your busy days to join us. Have a good night, everybody.